As you know, I'm Gayatri Shankar. Dr. Dodd's going to introduce Dr. Krol here, but can I take a moment to please remind you to sign in to Grand Rounds through our high mark system with the sheet of paper in front of you on your desk, or come find our CME person, Donna, right there, to help you do that. Please also remember to complete your evaluations at the end of the session. Again, I've said this before. Even if you may not need CME, you're a student or resident and don't need it officially right now, it is very important for us because that's how we know who's here and calculate our attendance, as well as have the ability to bring these wonderful grand rounds to you month after month, year after year. So without further ado, Dr. Dodd and Dr. Krol.
So I think everybody, pretty much everybody has had the pleasure of hearing Dr. Krol over the last hour, but for those of you who are not familiar with him, Dr. Krol is the section chair on the AAP section on oral health. He joins us from Rutgers University, where he both practices in pediatrics and is a researcher with the School of Dental Medicine there, where he researches both dental health and weight loss. So Dr. Krol has numerous research publications and invited talks on this subject, so please join me in welcoming him.
Thank you. Thanks, everybody. Can folks hear me in the back corner there? Okay, great. I'm so sorry that you all can't see me. Maybe it's better for you that you can't see me. So thanks, everyone, for being here. Thanks for those of you who have sat through 2 talks already of mine and now here for a 3rd one. For those of you who were here first thing in the morning, a lot of what you're going to see, most of what you're going to see here is a lot of the same. So I apologize for that, and also hope I do an even better job of presenting it this time. My disclosure, I don't have any disclosures to make here. I'm not making any money off any of the dental groups. I do want to say that fluoride varnish, the application of fluoride varnish for the prevention of dental caries, is an off-label use for kids. Not a big deal. We do a lot of things that are off-label for kids simply because not a lot of research is done on kids when it comes to medications and other things. But it's just important to say that as I go forward. So what are the things that you should know when we're done? So first of all, it's important to know how to speak the language. Dentists speak a different language than we do, and having lived a life of trying to communicate with them over the past 18 years, I've learned that I've needed to learn a different language. We'll learn about prevalence and distribution of the disease, dental caries specifically, tooth decay.
Attention, please. Rapid responders, 2300. Rapid responders, 2300.
Anybody need to go? All right. We'll talk about the pathophysiology of dental caries and how to intervene. And along the way, we'll talk about some policy and advocacy steps. We'll also touch a little bit on fluoride varnish, but not to the depth that we did in the morning presentation. So first of all, there's no such thing as a diabetes, right? It's diabetes. You don't have a diabetes, you have diabetes. Same thing with dental caries. You don't have a carie, you have dental caries. Dental caries is a disease process. The thing that cavities are a hole, okay? Cavities are the actual hole in the teeth. The caries process is what leads to the hole in the tooth, cavities. So it's one of my biggest pet peeves, and actually dentists get really peeved when one of us pediatricians will say, oh, he has a carie. Like, no, he does not have a carie. Do you have a diabetes? No, you don't have a diabetes. So just something to keep in mind. I'll save you from any grief to get from any of your dental colleagues. It's the same idea as if we were, so the disease of dental caries we want to try to prevent. The hole is the end product of all of that. It's as if we were treating diabetes with a kidney transplant, or treating diabetes with a toe or a foot amputation. We don't want to do that. We want to try to address the disease earlier on in the process so we can prevent these kinds of things. In the case of diabetes, amputations or transplantations. In the case of dental caries, extractions or fillings. All right, so very important to remember. So is this really a problem? I mean, do kids really have dental disease? I probably don't need to explain this to you, but for some communities, I do need to explain this to. So it is the most common disease of childhood. It's 5 times more common than asthma in kids. About a quarter of kids aged 2 to 5 have had decay in their primary teeth, and this is getting worse. If you look at NHANES, which is the National Health and Nutrition Examination Survey that keeps track of these kinds of things in the United States, the only group in the United States where dental disease is getting worse is 2 to 5-year-olds. And to me, that's the comment not on the dental community, but on the medical community, that we're not doing a great job of preventing this disease, and we need to do better. By adolescence, 3 out of 5 kids in the U.S. have had some kind of dental disease in their permanent teeth, and that's probably because they had disease in their primary teeth. And 15% of those kids haven't had any of this treated, so they're walking around with pain, most likely. Significant inequities exist in the United States. You know about inequities that between white and black, rich and poor, rural and urban, and you probably see a lot of that here. Poor and minority kids, when it comes to dental decay, have twice the disease and half the access to care. Twice the disease and half the access to care. The kids that need the care the most are the ones that are least likely to get it. It's an incredibly important advocacy. If I can convince 1 or 2 of you out of this group to be an oral health champion and wherever you go in the United States, please join me in doing that. This is an incredibly significant problem and one that has to be addressed. So how about Tennessee? So Tennessee, we don't have great data. That's a problem that I think needs to be addressed here in Tennessee, but let's just look at a couple things. So what you see in front of you is a percentage of kids with a dental visit in the past 12 months. What you'll notice, at least across children with Medicaid coverage, it's actually improved over the last 3 measures, 2000, 2005, and 2013. It's still only about half of the kids that have had a dental visit in the last year, which is not great, but it's better than it used to be. It's actually even better. It's actually even better than the U.S. average, which is pretty pathetic when it comes to the United States on how we're doing in getting kids into access to care, but it's something to keep in mind. And those things vary based on whether you have private insurance here in the middle or insurance that's Medicaid. There's a difference between those two. So there's an opportunity for advocacy here, advocating for dentist availability in rural areas, improving payment when it comes to Medicaid. I know pediatricians can benefit from that as well as pediatric dentists. So please join me in advocating for those kinds of things. Sealants. I'm not sure how many of you people know what sealants are or how many people you have sealants or had sealants. There aren't a lot of things in dental medicine that are truly evidence-based. The world of evidence-based dentistry is about a decade and a half behind evidence-based medicine. What we do know, however, is that sealants prevent decay. There's a lot of evidence to show that. All sealants are coverings. They cover the molars, the pit and fissure surfaces, the chewing surfaces of the teeth, and they keep sugars and bacteria from getting access to those pits and fissures and protect from decay without affecting the chewing ability. An incredibly evidence-based resource. Unfortunately, only 15% of Tennessee kids on Medicaid get dental sealants. Another opportunity for advocacy is trying to make sure that kids get dental sealants here in Tennessee. One final piece of data. These dentists, primarily because of reimbursement rates in Medicaid, but there are some other reasons. I actually did a report on this when I was an early faculty member at Columbia. the three main reasons dentists don't want to see patients on Medicaid. Reimbursement was the first, paperwork was the second, and the third was patient characteristics, which were things like they bring the whole family into my office, they're always late for appointments, they never follow up, they're loud, those kinds of things. These sort of biases against populations who are served by Medicaid. So something that's really important is to advocate, again, advocating for dentist participation, but also increase in payment. We really aren't very well paid by Medicaid, even as pediatricians. If you look at just compare Medicaid to Medicare reimbursement rates, we don't even get Medicare reimbursement rates, let alone private insurance reimbursement rates. So that's something to advocate for on a national level if you're interested in advocating nationally. So an opportunity there. So let's talk about the Caries Balance. So what's going on in your mouth is this common and complete balance between demineralization and remineralization, the breakdown of the tooth surface and the resurfacing of the tooth surface. As you're eating right now, the acid level in your mouth, the pH at the level of your enamel has dropped. And over time, your saliva is going to buffer that back up to the normal range. Now that's fine, that's completely normal. What happens though is if you have things like, if the microbiome in your mouth, the microbiome is the array of bacteria that live in an area. You have microbiome of gut, you have microbiome of mouth, you have microbiome of other surfaces all over your body. Because we're, a large percentage of us is not us, it's bacteria. But bacteria is one, acid-producing bacteria is one pathological factor. Fermentable carbohydrates, which is what you're eating, if you have any sugar anywhere in your food or if you have starches in your food today, that's another. And then saliva, especially when it's not, we don't have good saliva flow, either because there's some disease process that prevents it or because some physician gave you a medicine or a nurse practitioner gave you a medicine that decreased your saliva. So we'll go into more detail about these. But there are some protective factors. I already mentioned one, saliva, beautiful saliva. I'll talk a little bit about how much I love saliva. Then fluoride, calcium, and phosphate. And calcium and phosphate are in your saliva, but could also be as part of the diet. And then I'll talk a little bit less about, but still also interestingly important in a different ways, especially for adults, is antibacterials, which makes a lot of sense if this is a bacterial disease. So let's talk about bacteria. So the main culprits are mutans streptococci. So you know streptococci from strep pneumonia. This is a different type of streptococcus called mutans streptococci. There are also a couple of other culprits that are acidogenic, so they make acid, and acidophilic. They love being around other bacteria and make acid. So they're usually only about 1%, even less than 1% of the flora in your microbiome, in the plaque. But they produce acids and they live in acids. So let me I love giving this example. I'm going to pick on Dr. Wood and Dr. J. So you all are the bacteria in someone's mouth. All right, you're all little bacteria living your lives. And then there's Dr. Wood and Dr. J over here, the mutans streptococci. The acid-producing, acid-loving streptococci. Now, somebody has a toddler. Say you're in a toddler's mouth. A toddler has their sippy cup, and it has the blue juice in it, whatever that blue juice is. No child should drink something blue or eat something blue. That's my motto. And they're sipping on that, and suddenly it's sugar, and Dr. J and Dr. Wood are loving it, and they start making acid. And suddenly, these two beautiful, healthy bacteria are gone, and more Dr. Woods and more Dr. J's are made. And then it continues. Another sip on the sippy cup, like 20 minutes later, and more Dr. J's and Dr. Woods are made. And then another sippy cup drink, another half hour later, and more Dr. J's. Can you see how the flora, the microbiome can change because of diet? because these bacteria are making acid and reproducing and causing other bacteria to be present. This is why the microbiome is so important and why diet has such an important impact on this disease. So it's a transmissible disease. So it's not only an infectious disease, it's transmissible. Not in the way that the common cold is transmissible. Well, I suppose in some ways it is. So let's see, I'm a mom, or I'm a dad, and I'm carrying baby, and baby's binky falls out and falls on the floor. I pick up the binky, I clean it off in my mouth, and I put it back in baby mouth. How many of you've seen that? Has anybody seen that? All right. So what better way to inoculate a baby with your bacteria, and maybe bad bacteria, than to take it from your mouth and stick it in their mouth? I really can't think of a better way to do that. What's another example? Daddy takes a bite, mommy takes a bite. Daddy takes a bite, mommy takes a bite. Another way to transfer bacteria through saliva from another baby. So there is a transmissibility. It's primarily moms. Sorry, those of you who are moms out there. It's just that you all are spending more time with the kids, but it's really any caregiver. And there's even some evidence to show that there's some horizontal transmission, especially in daycare settings, as if anything gets transferred in daycare settings, right? You can imagine, I slobber all over the toy. I'm baby and I slobber all over the toy. Oh, and my neighbor steals it away from me like toddlers do, and they start slobbering all over the toy and sucking all over the toy. Another great way to inoculate each other with bacteria. So, transmissible infectious disease. Remember how I said a mouthful of Dr. Woods and Dr. J's would not be good? Even with fluoride, it's not going to overcome that bacterial load. If you have a high bacterial load in your mouth, you're not going to be able to overcome it simply with fluoride. There's got to be diet and other interventions, and we'll talk a little bit about that. And fillings, we just discussed that. That's not a way to treat dental caries. It's a way to fill a hole in a tooth, but it doesn't treat the disease process. You're way too far downstream. You got to move upstream to treat the disease process. So thank you to the dentist for filling the teeth. Incredibly important, but it's not the answer to preventing future holes in the teeth. It's the infection. So let's talk a little bit about the carbohydrates in this caries imbalance. So they're bad. They're absolutely bad. And we've just discussed what happens. So you've got the bacteria, you've got the Dr. Woods and Dr. I'm sorry, I'm just picking on you guys. It's kind of fun, but I hope you don't mind. You can get me later. Then you have the sugars and you've got the acid. That's the simplest way to describe tooth decay, dental caries, the dental disease process, is just this bacteria, sugar, acid, and time, right? And it's a frequency issue. It's not a volume. If I drink a whole 2-liter bottle of fill in the blank, it's not as bad as if I'm sipping on that 2-liter bottle all day long. And why might that be? Well, we'll get to that a little bit later. Here are the kinds of things you're going to see, or hope you don't see. But I'd rather have you see the things on the left than the things on the right. Because the things on the left, you can intervene. So the place you want to look, if you're going to look anywhere, look at the gum line. The gum line is where you're going to see the disease process start. You're going to start to see white lines. That's demineralization of the enamel, of the tooth enamel. That's reversible. Fluoride varnish, fluoride applications can reverse that process. Once the enamel is broken through into the dentin, it's not reversible. It's got to be filled. So that's unfortunately what we sometimes see on the right. We see kids like this. This is a relatively older kid, actually 2 different kids. These kids have to go to the OR. There's no way to deal with this in a dentist's office. You got to put the kid under. You've got to probably pull most of these teeth. Yeah, you're going to have to pull a lot of those teeth. You may be able to cap some of them, but most of those teeth are going to come out. There's no spacing for the next array of teeth. You're in big trouble. So here's what's going on. It's a frequency issue. So as I said, You take in your sugar, immediate drop at the level of the enamel. pH drops considerably. Acid is being produced. And over time, thanks to beautiful saliva, your pH starts to go back up. But you can imagine if another drink is taken here, it goes back down. And if another one's taken here, it goes back down. And another one here goes back down. You can never make it back to the normal range if there's constant intake. So it's a frequency issue, not a volume issue. Obesity, from a dietary sugar point of view, is a volume issue. Less so frequency, but frequency, if it added up together, becomes volume. But for dental caries, it's a frequency issue. So we want to try to decrease in between meal snacking, decrease in between meal sipping on sugary beverages. That's what's going to help us in the long run for this. That's where you can make a significant contribution. You may not even think of it as an oral health issue. You may think of it as an obesity issue. I'm discussing nutrition. I'm discussing get rid of the bottle at 12 months. I'm discussing don't put your baby to bed with a bottle. I'm discussing don't let your baby suck on the bottle all day long. We might think of those as nutrition issues or obesity issues, but they're also oral health issues. So you're doing some oral health work already. Let's talk a little bit about beautiful saliva. So saliva is the best thing going, one of the best things going. It's got so much. It not only acts as a buffer, it has calcium and phosphate in it. It might have fluoride in it if you're brushing teeth or if there's community water fluoridation or if you have supplements. It has proteins and lipids that forms the pellicle that protects the tooth surface. It keeps calcium in solution in a supersaturation. So when it's time for the calcium to enter the enamel, the lattice structure of the enamel, it can get in there. And as I said, it has some buffering and it even has some immunoglobulins that can fight off the bacteria. So there's an opportunity. The action here is protect saliva if you can. So address diseases that might be decreasing saliva and try your best to keep an eye on the medications we're giving our kids that might be decreasing salivary output that are xerostomach medications causing dry mouth. So keep an eye on that because there are a lot of meds that do that. The list is way too long to even go through here. So now let's talk a little bit about fluoride. So if saliva's awesome, fluoride's awesomer. Awesomer? Okay, I wrote that. I don't know why I did that. So the fluoride is primarily topical. There's value in community water fluoridation, the systemic, but the topical approach is the most important. Toothpaste, fluoride varnish, even some rinses, although less so for rinses. It not only inhibits demineralization, but it also enhances remineralization. So the remineralization is really fantastic, and I'll show you one quick slide of biochemistry. I apologize, but I'm going to show it anyway, that when fluoride is added to the crystal lattice structure of the tooth, it changes the structure from something called hydroxyapatite, which is incredibly susceptible to acid degradation, to something called fluoroapatite that has decreased susceptibility to acid degradation. It can also inhibit plaque. So here's your biochem slide. Don't fall asleep. I know I could not stand biochemistry. I apologize for those biochemists in the room. But this is essentially what's happening is with fluoride, you're changing the crystal lattice structure of the tooth enamel from this hydroxyapatite to a fluoroapatite that's more resistant to decay. That's why fluoride is so important. Community water fluoridation. I don't know, I'm sure that I'm dating myself, but there's a movie called Dr. Strangelove. And if any of you have ever seen it, it's a really funny movie. It's both scary and funny at the same time, especially in, well, I'll just stop there. But basically the gist of it is there was this general, the guy on the right, who was totally wackadoodle, like had totally lost it. And he was convinced that community water fluoridation was a Russian plot of mind control, and this took place in the Cold War, so it's a little dated, but it's still and Peter Sellers is one of the funniest guys ever. So community water fluoridation, one of the greatest public health achievements of the 20th century. The CDC said that, not me. It has both pre and post-eruptive effects. It was really wonderful to see when I looked, almost 90% of the Tennessee population that's on community water systems is fluoridated. And the AAP, Family Medicine, the Department of Defense, the Indian Health Service, the World Health Organization, all have come out in favor of community water fluoridation. There's a website called I Like My Teeth if you're interested in information on water fluoridation, or in the future, if you're advocating for water fluoridation in your communities, that's a place to go. So that's an opportunity for advocacy there. Here's some of the local water systems around this area. I'm not as familiar with this area as I probably could and should be, but Carter, Sullivan, and Washington counties. One thing to point out, Elizabethton, the water has been fluoridated there for over 50 years. It's one of the first communities in Tennessee to have fluoridated water, which is really awesome. But just something to consider in your patients. It's good to know, what water systems they're on to see if they actually have access to fluoridated water. Another opportunity for advocacy here. So what does AAP say about fluoride toothpaste? So toothpaste, basically AAP says if you have teeth, you can use toothpaste. It used to be where you waited till you were 2 or 3 years old to use toothpaste. In fact, I don't think you still have but if you look on the back of your toothpaste thing, it still says for children younger, on some of them, if it's children younger than 2 or 3, go talk to your dentist. That's changed. All the organizations agree now that you can start fluoridated toothpaste as soon as the tooth erupts. It's simply a smear. So what I tell my patients is if the tip of my finger is the toothbrush, you're just going to go perpendicular and put a smear on it. That's it. That's all you want to use for those little kids. Once they hit age 3, you can do something about the size of a pea. If they don't know what a pea is, you can say about the size of a grain of rice. You want a small amount on your toothpaste. That big swoopty that the toothpaste commercials will tell you to put on there, that's because they're selling toothpaste. They want you to use up that roll of toothpaste so you can get another roll of toothpaste. That's not what you're supposed to do. You don't need to look like a rabid dog after you get done brushing your teeth. Parents should supervise toothbrushing. My kids, when my kids are 9 and 10 now, when they were 4 or 5, they'd go upstairs. It was like their showers. It was the same way. Did you brush your teeth? Yeah. And when I would watch them, it would be done. That was it. That's not brushing teeth. Watch your kids brush their teeth. And then you can put fluoride varnish. Pediatricians can put fluoride varnish every 3 to 6 months when the tooth came up as well to be helpful. They don't need fluoride rinses before 6 years of age. You see those fluoride rinses. Some are bubblegum flavored. My kids absolutely love them. They don't need them, but they love them. But that's another opportunity. So that's an intervention that we can have, is teaching about fluoride toothpaste. So fluoride varnish, let me talk a little bit about that. So this is one of the unit doses. There's the fluoride varnish there. There's a little brush that you use. It does not take a lot of skill to do fluoride varnish. If I can do fluoride varnish, anybody can do fluoride varnish. My fine motor skills are not the greatest. TennCare pays for it, which is wonderful. I know your residency directors and your leadership know a lot about this, and I'm going to give them more information about what they can do for fluoride varnish. Really can make a difference for kids, especially if kids can't get to a dentist quickly. So there's an opportunity. So what fluoride varnish really is this thick, kind of pine sappy. It's pine sappy because the colophony that it's in, the resin that it's in, is actually connected or related to pine sap. But you just apply it to the teeth very thinly. It doesn't take a skill. You just put it on there, and it goes right into the tooth. It's not distributed systemically. It just goes right into the tooth and helps prevent new cavities, but also reverses those white spot lesions that we saw in those pictures earlier on. Makes a significant difference and can decrease rates of caries significantly in populations. It's been used in other countries for over 30 years. In the US, it's been around, at least for physicians to put on it, for medical providers to put on it, for about 11 or 12 years. I still have the bruises from the meeting with the American Academy of Pediatric Dentistry when we were talking to them about physicians using fluoride varnish. They were worried that we were going to try to start doing dentistry or wanted to be dentists, which was the furthest thing from our minds. It was we wanted our kids to have better oral health. But as I said, the FDA has approved it as a cavity liner, not as a preventive dental mechanism. But dentists are using it off-label. We can use it off-label. There are really no harms to the child at all. There's no toxic effects. The safety profile is really pretty well delineated. Most of the data in the U.S. has come from a program called Into the Mouths of Babes from North Carolina. Gary Rozier and his group have done meticulous studies. It's really fantastic what they've done. They've looked at caries, the effect of fluoride on caries rates. They've looked at it on access to dental care. They've looked at missed school days. They looked at cost. And they've even looked at cost effectiveness. They've done cost effectiveness analyses on fluoride varnish. Suffice to say, the evidence was so great that the U.S. Preventive Services Task Force recommended that primary care physicians can apply it from birth up to 5 years of age. They gave that a grade B, which basically means that insurers need to be paying for this and that parents shouldn't have to pay a copay for it, which was a wonderful thing. That wasn't the end of the advocacy. We actually had to do a lot of advocacy to get a CPT code for it and to get then a Medicare to give it a relative value unit. But that's beyond the scope of this presentation. I'll talk briefly about the antibacterials because, as you might expect, in infectious disease, there's value in antibacterials. You might wonder, why isn't there just a vaccine for dental caries, right? It's a bacterial disease. Why haven't we come up with a vaccine against it? Well, folks, this is sort of the holy grail of dental caries research, is trying to find a vaccine for dental caries. The biggest challenge has been, one, it's not just one bacterium. So mutans streptococci are the most common, but there are others like lactobacillus and others. And so trying to find a vaccine that focuses solely on those without eradicating the rest of the oral bacteria, the oral microbiome, has been really challenging. The second, it's as if yes, you could kill all the bacteria in your mouth by rinsing with Listerine, right? You can kill all the bacteria in your mouth that way, but they all grow back, always grow back in the same proportions, and you haven't really done much selection of the bad versus the good. So there's a couple of them. They're usually used in adults, although they've started to do some trials in kids, especially in Native American populations, because they have the highest rates of dental disease and the most severe early childhood caries. And there's some evidence to show that there's some sort of genetic predisposition. It's not just diet, but they have really high rates of disease and really virulent disease. So a lot of what they're trying to do is break this cycle of transmission from mom to baby. So what they've started doing is giving moms these chlorhexidine rinses, which are like Listerine. They basically kill everything in the mouth to prevent the transmission to the babies. There's also something called xylitol, and some of you may have seen it on the labels of your gum, your sugarless gum, or if you know research on ear infections, the early research on ear infections from Finland and Sweden, they use xylitol there to try to prevent, it has an effect on streptococci. And they're starting to do not only xylitol lozenges in mothers, xylitol gums, but also xylitol wipes in babies. There's even, if any of you ever get to go to the American Academy of Pediatrics annual meeting or to some of the other National Pediatrics meeting, there's a company called Spiffy's that makes these xylitol wipes that you can just wipe kids' teeth with the xylitol. And there's some evidence, there's unpublished data to show that there's some value in that too. The negative is that you have to have a lot of it. You've got to chew gum. The mothers have to chew gum 4 times a day. I mean, it's almost ridiculous the amount of time that you have to spend with it. Okay, so I guess I've discussed the xylitol. So what's our approach to risk assessment? So the first, as far as risk or disease indicators, I remember it by the acronym REC. It's white spots, it's restorations, it's enamel lesions, and it's cavities. So if you look in a kid's mouth and you see any of those things, they've definitely got disease. All right, so that's an important, that should ring a bell that you need to intervene in some way, or you need to get that kid to the dentist as soon as possible. If they don't already have a dental home, we need to try to find them one. We talked about what you might see. Those are the kinds of things we're going to try to prevent or reverse. Then the risk assessment. We need to assess how high risk they are. And what can help us do that? The acronym BAD. And we talked about this. It's bad bacteria, it's the absence of saliva, and it's dietary habits. So those are the kinds of things we're going to be asking about and trying to modulate. Less so with the bad bacteria, except with fluoride. But saliva, we can, prevent ourselves or try to find ways to decrease the frequency or the amount of medications that are decreasing saliva flow. And we can do a lot about trying to change dietary behaviors and improve the nutrition of our kids. And then the protective factors we went over, that's safe, that's saliva, antibacterials, fluoride, and effective diet. And if we can do those things, we can keep this Caries balance in balance without it tipping towards the demineralization and getting disease, getting a cavity. I'm going to mention 1 or 2 other things while I have you. Silver diamine fluoride, you may see this in your practice. I don't know how many dentists are doing this in Tennessee, but in other parts of the country it's starting to increase. Most of you have had the opportunity to use silver nitrate, the sticks, for umbilical granulomas. Similar idea. Why do we do that? Or why do we use silver diamine fluoride? Well, it's an opportunity to arrest decay, including cavities. So this is placed directly in the cavity. It stops the disease process. It absolutely stops the disease process. It doesn't help the tooth remineralize, but it stops the disease process where if you can't get a kid to a dentist, or it's a child with special health care needs, so it's very difficult to get in to see a dentist because not a lot of dentists are capable of taking care of those kids, you'll see some of this to address dental disease in kids' mouths. I guess I've talked about all that. Staining is the real issue here, so you got to be really careful. And if you've ever gotten the silver nitrate on yourselves, it just stains. You have to almost have to roll up your sleeves when you're doing that, so you're not getting it all over your arms. So what can we be doing? So it's ask, look, decide, act, and document. We ask to find out their history. Do they have access to a dentist? We look inside the mouth. I'm not sure what your electronic record looks like or what it will look like wherever you practice. But usually H-E-E-N-T, the T doesn't mean teeth, it means throat. Please remember to look at the teeth. It should be a H-E-E, a he-not, like H-E-E-N oral and teeth, or it should be H-E-N-T-T. So just making it part of the electronic record can help us remember to look in the mouth. So I think that's really important. We need to decide what we want to do once we see what we see and what we hear. We want to act. We either want to put fluoride varnish on or get the kid connected to the dental office to a dental home, and then we want to document these things. If a child has dental caries, put that in their record so we can follow that over time, just like any other thing we might discover in a physical exam or in a history. Just a couple of things that I think are really cool that exist right now. There's something called Brush Book in Bed. I know you do Reach Out and Read here. It's a similar where it's tying together this routine. It's all about routines for kids, as you know. And this routine is brushing the teeth, reading a book, and going to bed. And it's a program run by the American Academy of Pediatrics. There's a lot of great resources. If you're interested in it, you can share them, both English and Spanish, if you're taking care of Spanish-speaking populations. There's a lot of great information there. There's also, as I mentioned, that great resource on water fluoridation called I Like My Teeth that has a lot of information on water fluoridation. I'll mention some of these here. The Tennessee chapter of the AAP, which I hope you'll become a member of the AAP. You may be as residents. Hope you'll stay that way as pediatricians in practice, and hope you'll join the section on oral health. I guess I can't leave here without putting in a plug for this section on oral health. Please join. There's a lot of great resources there. We'd love to have you. We have a resident representative on their executive committee, so if any of you are interested, keep an eye out for that. And then just the final thing I'll mention is there's this great website called 2min2x. It's brought to you by the same folks that did the crash test dummies. It's the Ad Council that put this thing together, along with some help from the American Dental Association. And I used it with my kids. It's actually these little videos of characters like Elmo or a variety of different characters with a 2-minute video. And the kids can brush their teeth while they're watching the video. It's 2 minutes. And I would do it with my kids just to make sure that they would stand in one place for 2 minutes. Because as you know, you've probably experienced, kids now, the little kids are just buried in phones and tablets and things like that. Well, this was an opportunity to try to take advantage of that by putting in an oral health message. So I will stop there. I am not sure if I'm over time or too far under. I guess I'm pretty close. What questions can I answer? Anything that I can talk to you about, tell you about in oral health? How can I be helpful? Yes?
Thank you for a wonderful, wonderful talk.
Thanks.
I have a question about sort of sour candy. You know, obviously you talked about sweets and candy and carbohydrates and how all of that's horrible to bring down the acid level in our mouth flora. What about sour candy? I know that that's quote unquote acidic.
Yeah.
And at the same time, it probably stimulates our saliva. So
Yeah.
What's the weight, which direction?
Yeah, so thanks for that question. That's a really great question. So you're balancing the potential sugar content in a sweet with the sialagogue, basically the thing that causes saliva flow. My answer to that is there are sugar-free sour candies that you can use that are equally effective in leading to saliva flow. So I would, if they're going to have sour candies, push them towards the sugar-free ones rather than the sugar-loaded ones. Because the hard candies, I'd actually much rather have a kid eat a candy bar than have a sour candy, because the sour candy stays in the mouth longer. You know, kids wolf down the candy bar and it's gone. The sour candy's in the mouth, usually sitting right at the gum line. I'd suggest that. And there are plenty of sugar-free sour candies out there that you can use. I've actually, you know, for kids who really love those, or the parents who want to use those as a reward, I point them towards the sugar-free ones. But thanks for that question. It's really important because it is one strategy of getting saliva flowing in patients. Yes?
There's the xylitol lollipops that are like giveaways sometimes for the older children in
Yeah.
the clinic. Are those useful? Should we be?
Yeah, you know, there's actually a study going on right now that's evaluating just that, the xylitol lollipops, rather than a mint or a chewing gum. I haven't seen any of the results yet. It's valuable. As I said earlier, the data on xylitol you have to use it quite frequently. So they'd have to be having these lollipops twice or 3 times a day. So there aren't any negative effects of the xylitol lollipop, and there probably aren't many positive effects for that one-time use or that infrequent use. It's better than a regular lollipop. I'll say that. It's better than a regular lollipop. You know, there's gums out there, I think, I can't remember which one it was, maybe Orbit or something, where xylitol was the first sugar on it. But there's some, if you want to use that kind of gum, those are great. But yeah, you know, for the one-time use, the relatively infrequent use probably doesn't make a whole heck of a lot of difference. But over time, it might. I think that's easy. Yes?
I may have missed this. Is there any relationship of oral health to the use of probiotics?
There's a lot of research being done on that right now, especially with probiotic rinses. Not a lot with probiotic supplements, because they're usually affecting the gut microbiome rather than the oral microbiome. But there's some studies being done right now on probiotic rinses. So it actually spends more time in the mouth. And I don't know the literature really well, but the folks that I know who are doing that work are really excited by these. I have a feeling, though, it's going to be very similar to xylitol, where you're probably going to have to rinse 2 or 3 times a day to really get the impact, because you're sure not going to be walking around part of the day with a mouthful of probiotic in your mouth. You know, you just won't be able to function.
So we should invent a toothpaste with probiotic in it now.
Potentially, yeah. It might be. There you go. Yeah. Yes.
Along those lines, I think I remember reading maybe a decade ago about they were inoculating newborns with healthy oral bacteria. And it seemed very exciting and promising. They thought they could eradicate.
Yeah.
Could you repeat that?
Yeah, so the question was, he had read that there was some studies where they were inoculating healthy bacteria into the mouths of infants, or at least young toddlers. I remember seeing that study as well. There were a couple of studies that were doing that. I haven't seen a lot of follow-up to that, so I don't know what the result was. It's an interesting idea. I mean, it's definitely being done in gut microbiome. Where fecal transplants and things like that, where we're trying to improve the microbiome, the gut microbiome. It'd be interesting to see, you know, and really the mouth is just an extension of the gut. It'd be interesting to see how they would do that with an oral microbiome, and it might be toothpaste. It might be some sort of delivery mechanism like that. I'll have to ask next time I talk to the Colgate and the Procter & Gamble folks, see what kinds of things they're working on in that area. That would be really interesting. I'd be interesting to hear how they would sell that, to what their marketing scheme would be for a probiotic for the mouth rather than just for the gut.
Probiotics come as a sachet packet or as a liquid probiotic. So
Yeah.
it is going into the mouth.
Yeah. I think the evidence that I've seen so far about the probiotics in their current form, they're not having that much of an impact on the oral microbiome, just on the gut microbiome. But if there was a different delivery mechanism where it could spend an increased amount of time in the mouth, it might work. Maybe it's a hard candy that it's a probiotic or something like that. It's creative. Hey, you guys might have just thought of the next $1 million ideas, right? Feed the fish mayonnaise. What?
And this is just a comment, Dr. Krol. I really, truly appreciated your comment on sugary substance in the mouth, of the frequency versus, like, you know, the dose piece. And I think we're big advocates of no juice all the time.
Mm-hmm.
And that's great. Lots of times I have families and even students come tell me, well, they're not drinking that much juice. It's only 2 ounces when you think about it, because grandma waters it down. but then they have this sippy cup of watered down juice that they're drinking all day long.
Yeah.
So I try to partner with families and tell them, give them that 2 ounces. Fine,
Yeah.
But give it to them and then wash it down with water and let
Right.
them have just water in their sippy cup at other times.
Yeah.
So I think that frequency piece is really, I love that slide where every 10 minutes
Yeah.
the acid goes down. You're not ever going to reach kind of a good pH.
Yeah, if you can make the case that only with meals or something like that, as long as it's not constant snacking, then maybe it's more tolerable if your patient's drinking juice. But yeah, I mean, sippy cups are hard. You know, I'm a parent of 3 kids, and boy, there's a lot of convenience of a sippy cup and a lot less work if you got a sippy cup versus trying to sit there and hold the cup for your kids so they can drink it and not have to wipe up after them. But, you know, to me, a sippy cup is just a bottle without a nipple. And it's a delivery mechanism it's a potential delivery mechanism for something that can cause significant disease. A sippy cup with water, go for it. Love it. But a sippy cup with any sort of sugary substance, you're just asking for trouble. Yes?
I have a comment and a question. My comment would be that xylitol is harmful to dogs, so it's
Oh, thank you.
a little bit of trivia to know when you're counseling patients if something does become available to help improve kids' oral health. And my question would be, for this fluoride varnish intervention, are there any benefits, like on a population level later on in life, diseases that may prevent or health issues that improved oral health may prevent later on in life?
For fluoride varnish, not that I'm aware of. And just let me make sure I understand the question. You're asking if the application of fluoride varnish can have an impact on health later on down the road, positive or negative?
Sure. I remember reading some articles a few years ago, I believe, about poor oral health in adults having impacts on cardiovascular disease.
Oh, absolutely. Oh, yes, absolutely. So the oral systemic connection, there's more and more evidence coming out. So yes, if you can keep teeth healthy when kids are young, they're more likely to have healthy teeth when they're older. The diseases more frequent in adults tend towards periodontal disease rather than dental caries, although dental caries can happen in adults. There's more and more evidence coming out between the relationship of periodontal disease and diabetes. And that's that's an easy one to wrap your head around. If you have a massive infection over a large surface area and you're trying to control a type 1A or an hemoglobin A1C, you have a hard time doing that. So there's a lot of evidence there. There's some evidence around periodontal disease and cardiovascular disease, specifically atherosclerosis. And for a while there was some pretty good evidence on the association between periodontal disease and preterm birth. They actually did a big randomized controlled trial where they treated moms with periodontal disease, and they really didn't find that the treatment made much of a difference. But more and more evidence every day is coming out about oral systemic relationships. And so yes, if you can maintain oral health, the longer you can prevent a child from getting the disease, the better off they are as they grow older, the better a chance they have of keeping their teeth when they're older. Thank you, everyone. Thanks for sticking it out.